When I first started working as a nurse, the hospital seemed like the least normal place I had ever been in.
We stick tubes in every possible orifice, slice people open to save their lives, fill their veins with poison, measure their urine, count their bowel movements.
The craziness is normal, and the only thing that's really normal is the fundamental humanness that unites us all.
Working as a floor nurse is messy and stressful, but I wouldn't exchange it, not in a million years, not ever. But where else can I go to sample daily the richness of life in all its profound chaos?
Teresa, do you need help?
I think I had a sort of deer in the headlights look on my face, and I mumbled, uh-huh. I gave Tom his noon pills, his noon antibiotic, and his IV steroids, while the other two nurses hooked him up to an oxygen tank and piled his belongings on top of his bed and in a wheelchair.
The lab technician still had not come to draw the tobramycin level, so I called her back and left a message saying the patient was going to be transferred to the ICU, and could she draw the level there?
Marla wanted to take a shower, so she needed to be disconnected from her IV fluids.
Dorothy's back pain was flaring up, and she wanted more morphine. She also needed her insulin and was feeling nauseated. I asked 2 other nurses to help.
Then the 3 of us got Tom rolling. In the maybe 5 minutes it took us to get him out of his room, my phone rang 3 times.
The first call was the lab technician calling me back to say she had been at lunch and could the ICU nurse draw the Tober levels.
I wanted to say, lunch? You get a lunch?
He was young, in his 20s, and had undergone an allogeneic cell transplant as the only chance of curing his cancer. A virus had turned his urine red with blood. His transplanted cells attacked his own body, leaving him temporarily blind.
Every time he stood up, he leaked blood. Then his mind started to fail too.
His doctors continued to throw one last-ditch treatment after another at him. Not one of them made a real difference in the patient's condition.
But more than that, we prolonged his suffering, racked his body with one toxic treatment after another, and held out false hope to him and to his parents. Taking care of this patient, we yearned for a more humane job. As one nurse put it,
This is torture.
the young man wasn't my patient, but as time passed, I began to feel deeply ashamed of what we were doing to him.
The professional label for the feelings that we nurses had is moral distress. The anxiety, fatigue, and hopelessness that providers experience in the face of medically futile care.
It's estimated that as many as 15 to 25% of nurses quit their jobs as a result of moral distress.
Never to return.
The thing I remember most is that by the end I was sweating.
I had been nervous, and the blue gowns we wear for protection are plastic and hot. The patient thanked me and said I had done a good job, a sure sign he had spent way too much time on the floor.
Still, I had done it. I had given my first chemo. I had been initiated into the potentially life-saving part of oncology nursing. And it gave me a rush I hadn't anticipated. This is power, I thought. And the realization scared me.
As a nursing student, I had held a human heart in my hands.
I remember the feeling of power as I held it, but an even stronger feeling of awe. Chemo is both less elegant and less universally effective than the human heart. But in addition to a feeling of power, it also invokes a sense of awe, not the least of which is the trust patients show nurses when they allow us to inject these poisons into their veins.
One day, I had prepared to give chemo when the I was administering it to said,
What does it mean that you're all dressed up in that special gown and you're shooting that stuff right into my veins?
well, I said, with us, they worry about cumulative effects, which is true, but only half true. These drugs are dangerous biohazards. Our gloves and gowns get thrown away in special trash cans marked
For chemotherapeutic waste.